In 1880, a French neurologist named Jules Cotard presented a case to the Paris Biological Society that nobody in the room had ever heard of before. His patient, a woman he called Mademoiselle X, had come to believe that she had no brain, no nerves, no stomach, no intestines. She believed she was made of nothing but skin stretched over decomposing bone. She believed she was already dead, already rotting, already beyond any need for food or water or warmth. She didn't need to eat because dead things don't eat. She didn't need to sleep because the dead don't rest. She sat in the clinic and described herself the way someone might describe a piece of abandoned furniture. She eventually starved to death, still convinced she was already gone. Jules Cotard named the condition after himself, the Cotard delusion, also known, in the more plain language of the people who experience it, as walking corpse syndrome. Because that is what it is. You are walking. You are breathing. Every cell in your body is alive, and you are completely, unshakably, logically certain that you are dead. This is your story. Level 1, the before. You're 34 years old, and nothing about your life suggests what's coming. You've had depression before, a bad episode in your late 20s that lasted 8 months, during which getting out of bed felt like moving through concrete, and the things that were supposed to matter stopped mattering. You got through it with medication and therapy and time. You know what depression feels like. You know its particular texture. You think you would recognize it coming again. What starts this time doesn't feel like depression, or rather, it feels like depression's more disorienting cousin. A strange, pervasive sense of unreality has been creeping in over the past few weeks, a quality to daily experience that you can't quite articulate to anyone, like watching your own life through glass. Like the world outside you is slightly further away than it should be. You're present, but not quite inhabiting the present. Doing things, but observing yourself, do them from a slight distance. Psychiatrists have a name for this: depersonalization and derealization, a dissociative state that frequently precedes or accompanies serious mood episodes. The world and the self become unreal in a specific, disturbing way that stops short of delusion but feels like the border of one. You don't know this yet. You know that something feels wrong. You can't say what. Level 2, the first thought. It begins, as it begins in many documented cases, quietly, with a thought you almost dismiss. You're standing in the bathroom in the morning, looking in the mirror, and you notice something. The face looking back at you doesn't feel like yours. Not in the way that any face can look strange if you stare at it too long. Something more fundamental. The connection between the face in the mirror and the self doing the looking has loosened, the way a knot loosens when you pull the wrong strand. You look at your reflection, and something that should fire doesn't. Here is what's happening in your brain at this moment, and it's one of the most important pieces of neuroscience in this entire story. 2 brain regions that are normally in constant conversation have stopped talking to each other. The first is the fusiform face area, a part of the temporal lobe responsible for recognizing faces, including your own. The second is the amygdala, the brain's emotional core, which assigns feeling, familiarity, and significance to the things you perceive. In a healthy brain, these 2 regions work in tandem. You see your face. The fusiform area processes the visual information, passes it to the amygdala, which fires with the familiar warmth of recognition. This is you. This is yours. In your brain right now, that signal isn't arriving. The fusiform area is processing. The amygdala is silent. The neuroscientist V.S. Ramachandran, who has studied this class of conditions extensively, has described what happens next as the brain doing exactly what brains do. It looks at the available information, a face that is visually recognizable but emotionally empty, and tries to construct an explanation. And the only explanation that fits the data, the only narrative that resolves the paradox of a body you can see but cannot feel belongs to you, is the one your brain lands on now. You must be dead. The living feel present in themselves. You don't. Therefore, you must not be alive. It doesn't feel like a thought. It feels like a realization. Level 3. The logic of it. The terrifying thing about Cotard's delusion, the thing that separates it from ordinary irrational thinking, is how internally coherent it is. Your brain is not malfunctioning randomly. It has received an unusual signal, the profound disconnection between self-perception and self-feeling, and it has constructed the most logical available explanation for that signal. The problem is that the explanation is catastrophically wrong, but it doesn't feel wrong. It feels like the only thing that makes sense. Over the following days, the belief deepens. You move through the apartment doing ordinary things, making coffee, opening windows, looking at your phone, and underneath each action is the settled, quiet certainty that you are not alive, not in a frightened way. In an eerily calm way, death, you have concluded, is simply the state you're in now. Your sense of smell has changed. Food smells slightly off, slightly rotten, an olfactory hallucination that some Cotard's patients experience, the nose reporting what the mind already believes. Your food tastes like nothing. You're not hungry. Dead things aren't hungry. You stop eating consistently, not in distress, not in protest, simply because the need doesn't feel real. You look in the mirror, and what you see looks increasingly to you like a surface, not a face, not a person, a surface. The eyes move. The lips move when you speak. But the sense of inhabitation, the feeling that something is living behind that face, is simply gone. You can state, plainly, with complete composure, that there is nobody home in the body you're standing in. You can observe this the way you'd observe weather. Level 4, the people around you. 17 days after the bathroom mirror, your partner calls your sister. The thing that prompted the call wasn't something dramatic. It was something quiet. They'd asked you what you wanted for dinner, and you'd said it didn't matter. And when they'd pressed, you'd explained, without particular emotion, that you didn't need to eat anymore. When they asked why, you told them. You're dead. You've been dead for a couple of weeks. You're not sure why you're still moving around, but the moving around doesn't change the underlying fact. Your sister arrives the next morning. You are glad to see her in the abstract way. You're glad about most things, which is to say, not really glad, not emotionally engaged, but cognitively aware that this is someone you love and that her presence here means something even if it doesn't feel like it means anything. She asks how you are. You tell her the same thing you told your partner. You explain it patiently. You're not in distress. That's the part that frightens her most. Not that you believe it, but how calmly you believe it, as though you're reporting a medical diagnosis you received some time ago and have since accepted. She drives you to the hospital. Level 5. The diagnosis. The psychiatrist who sees you has encountered nihilistic delusions before, but not frequently. Cotard's delusion affects fewer than 1 in 1,000 psychiatric patients. The total number of documented cases in the entire medical literature is small enough that many psychiatrists complete their entire career without seeing one. She conducts the clinical interview carefully. She asks about what you believe. You tell her. No organs, no blood circulating. A body that is technically moving but functionally no longer alive. You describe this without drama, the way you describe a logistical situation. She notes the flatness of affect, the absence of distress that would accompany most people making these statements for the first time. An MRI and a CT scan are ordered to rule out neurological causes. Tumors, lesions, encephalitis, traumatic brain injury can all, in rare cases, produce Cotard-like symptoms by physically disrupting the frontoparietal circuits and temporal lobe connections involved in self-awareness and emotional processing. Your scans come back without obvious structural abnormality. The diagnosis is clinical. Cotard's delusion, arising in the context of a severe depressive episode with psychotic features. She explains what they're going to do. Antidepressants combined with antipsychotic medication to address the delusional architecture that has built itself on top of the mood disorder. And something else. Something that sounds, when described, more extreme than it is. Electroconvulsive therapy. Level 6. The treatment. ECT has an image problem. For most people, it calls up images from old films, metal plates, and violent seizures, and something that looks more like punishment than medicine. The reality of modern ECT is considerably different. You're under general anesthesia. The current passes through your brain for a fraction of a second, producing a controlled seizure in brain tissue rather than the visible convulsions of outdated depictions. You wake up groggy. Sometimes your memory of the hours surrounding the procedure is temporarily blurred. Mostly, you feel the same. But across sessions, something changes. The neuroscientific explanation for why ECT works in cases like yours is not fully understood, which is an honest thing to say about a treatment that consistently works better than anything else tried for severe Cotard's presentations. The best current understanding is that it does something the medications are too slow to do alone, a rapid reconfiguration of the neural connectivity patterns that have drifted into the disconnected state underlying the delusion. A reboot, in the informal language doctors sometimes use, of the circuit that's gone quiet. After your third session, something shifts. You're sitting in the hospital room, and your sister brings coffee and puts it in front of you, and you feel something, faint but real, a small, genuine pull toward it. Not because you've decided to eat, because something in you wants the coffee, because something in you is registering want. You sit with this for a long time. Something has come back that you didn't know had gone until this moment. Level 7. The reflection. You're discharged 6 weeks after your sister drove you to the hospital. You go home with a medication regimen, a follow-up schedule with the psychiatrist, and the residue of one of the stranger experiences the human brain is capable of producing. What you have now that you didn't have before is a specific, first-hand understanding of something most people only encounter as an abstract philosophical question. The sense of being alive, of inhabiting a body, of being present in your own existence is not a given. It is constructed, moment to moment, by the conversation between different regions of a brain that normally never misses a word of that conversation. When it misses the words, everything goes quiet in the most fundamental way possible. The belief that you were dead was not madness in the chaotic, disorganized sense. It was your brain, confronted with a profound absence of self-feeling, building the most coherent narrative it could from the information available. The brain always builds narratives. That's what brains do. When the signals feeding the narrative are wrong, the narrative is wrong. When the signals return, the narrative updates. The signals returned, the narrative updated. You still think about the mirror in the bathroom. The morning, the face looking back didn't feel like yours. You think about the 17 days of calm certainty that you were no longer alive. You think about what it means that a single disconnection between a face recognition system and an emotional response system, between two brain regions you'd never heard of before this happened, can unmoor a person from the basic fact of their own existence. And somewhere right now, a person is standing in a bathroom in the morning, looking at their reflection and feeling something strange they can't name. Not what you felt. Probably just tiredness, or the ordinary uncanniness of staring too long at a familiar thing until it becomes unfamiliar. Probably. But the brain is always one disconnection away from a different story about who's home inside it. Most of the time, the signal gets through. Most of the time, the face in the mirror fires back with warmth. Most of the time.